Sir, may start
Done.
this?
Done.
Yes, done. Sir.
Good evening to everyone. Happy to invite you all, our AP State branch members, postgraduate students, and non-members, if there are any. See, this is the first webinar program. Wednesday webinars, the Young Mind Summit. It is first of its kind, our state branch, and we wish to have it on every fourth Sunday, this sort of activity. Fourth Wednesday. It's mainly to encourage our young colleagues to exhibit their oratory skills and to share their knowledge, especially the recent advances in psychiatry. In this program, I must thank the CME Committee Chair, Dr. Ramana Rao, members, Dr. Vishal, Dr. Ranjit, and our constant well-wishers, Dr. Ramesh Balaji and Logeshwar Reddy, for their support and advice during sorting out all these organizing activities. I thank the Executive Committee and General Body for their support to initiate this program. We would like to have it every fourth Wednesday, and we'll encourage these things. Before starting, let us all together inaugurate the first program of the webinar today. Because this is the first program, let us have an inauguration by all of us.
Ramya.
Yes. Okay. Now I hand over the program to Dr. Ramana Rao garu.
Yeah. So good evening to all of you, and I thank the President and the Executive for giving me this opportunity. Am I audible, Sarat Chandra?
Yes, sir.
Yeah. Thank you. Today's topic is at-risk mental state. In the olden days, we used to call it as a prodrome for schizophrenia and all that. And the latter ultra high risk, clinical high risk, so many names are given to it. And at present, researchers mostly focus on at-risk mental state, which is more of a trans-diagnostic, diagnostic label, where previously people used to think that prodrome means it is the ultimate result is schizophrenia. But this broad term, we can envisage that any subthreshold symptoms may result transdiagnostically either into a psychosis, maybe a schizophreniform psychosis, or it could be a subthreshold symptoms of bipolar spectrum, and then or sometimes a mild variety of bipolar borderline personality disorder, or a substance abuse disorders, things like that. Now, this is a very broad term, which probably clinically also we come across. Like, for example, I have one patient, a very young dynamic engineer, a graduate who has gone to US from a very good family with a good family background and all that. He had gone with his friends and they are sharing the same room. And it's okay for some time, but later, I think there is an echo coming. Am I audible? Hello?
Yes,
Yeah. Am I audible?
Yes, sir. You're audible, sir. Go on.
Yeah. So he started having a suspicion that his friends were misplacing his documents, including his passport. He kept on phoning his mother, and even the mother was reassuring him, he could not stop complaining to the police. So it became a problem, and later he has to come back to India, and then he was shown to me, and absolutely is normal. There is no evidence of any psychosis or hallucinations or delusions, anything like that. But he's okay, and with a small dose of aripiprazole, he is completely normal, and has gone back to his job at US. Again, after some time, he has been again ringing his mother, saying that these things are happening. If you take the family history, his grandfather, who had very prestigious post as one of the directors of the company, he has developed his schizophrenia at the age of 30 years, and even today he is on medication. And his own sister, who is a doctor, medical doctor, had symptoms of OCD, and she was on surreptitious prescription of fluoxetine, and she could somehow complete her medicine, but later she never practiced nor appeared for any PG examination, and instead she has turned into spirituality, and her functioning has come down, socially withdrawn, and it looked, because they stopped the medication, because assuming that she'll be all right without medication, and the patient also never accepted medication. And recently she was coming for the follow-up, and she is on medication. She is doing well. So regarding this particular patient, who is otherwise normal, he doesn't have any features of hallucinations or delusions or a functional a deterioration. Otherwise, he is normal, quite normal. Does he require a medication? Does he require a treatment? So this is what is ARMS, that is at this mental state. So let us see how Dr. Prabhath is going to present his research findings and literature. And this is time for the chairperson to take over the charge. Next to Dr. Nagi Reddy K. Thank you. I request Dr. Nagi Reddy K.
Unmute, sir. Unmute.
Yeah.
Hello?
Yes,
Yeah,
sir.
yeah, you're audible.
Yeah?
Yeah.
Now I am listening, able to listen?
Yes, sir. Go on, sir.
Okay, okay. Thank you. Regarding to this at-risk mental states, sir, the seniors, many of seniors are here. We have been discussing this topic for the last almost 30 years. I think this term started in 1990, this particular term. Since then, in many conferences we have discussed, but we could never able to come any conclusion regarding the management of these patients. It's a very important topic, very tough topic. And at the same time, what my personal feeling is, my personal observation is, for the last 30 years we are practicing, we have all seen two generations of patients. Most of the patients, their mother or father are suffering with schizophrenia. If his son or daughter is at the age of 16, 18, 19 years, comes with some kind of problems, psychotic, minor psychological disturbances, then it's very difficult for us, very fearful to us how to deal with such kind of patients. So we know that strong family history is there, but there are no significant psychological psychiatric symptoms, strong delusions and hallucinations to which meet diagnostic criteria of DSM-5 or ICD-11. Then we will be having a lot of confusion. So that's why it is a day-to-day problem. Daily we are worrying about this problem. And another thing is, many long-term studies also, there are only 30 to 40% of the patients of these ARMS patients are going to develop psychosis in future. So that means 60 to 70% of the patients may not require any kind of treatment. Again, how to identify these 30-40% of the patients? That is a very difficult thing. Whether this kind of newer neuroradiological methods, biomarkers, genetic markers are giving any hope to diagnose this specific 30 to 40% of patients which may require treatment. That we still have not any proper consistent conclusions. Today, I invite our speaker, young dynamic speaker, Dr. Prabhath. He did his MD from Guntur Medical College. After that, he did his MD from MBBS from Guntur Medical College, MD from Katuri Medical College. After that, he joined in Vizag, KMC, and did his senior residency. Later, he joined as assistant professor there itself. Now he is working in government hospital for mental care in Vizag. So I request Dr. Prabhath to take the floor and deliver his lecture. Because mainly, I wish him to concentrate on mainly on recent advances, recent studies. What are the recent views regarding the management of ARMS patients? Patients, ARMS candidates. Now, floor is yours, Prabhath.
Sir, thank you so much, sir. Sir, before I sir, am I audible?
Yes, Prabhath.
Sir, before I go into the topic proper, I would like to thank Lokesh sir for introducing me to this topic. So he asked me to present first, then GVS Murthy sir asked me to present. So then I went into the topic and found it very interesting. Then I thank IVL Narasimha Rao sir for accepting their proposal. And actually, finally, I want to thank our superintendent sir for making this happen in our institute and making all these arrangements. Sir, now I would like to go into the topic proper. Sir, I'm sharing the screen now. Sir, is it visible?
Yes, sir.
Yes.
Yeah, now it is visible.
Okay, sir. So, at-risk mental state. So, as sir was saying, the topic has been around for a while. The concept exists since 1900, so it's been more than a century now. So, poly meal. This was actually, and this is actually an important question even now for the postgraduates who actually proposed the concept of schizotaxia, schizoseme theory. He was an American psychologist who actually conflicted with the prevailing notion that schizophrenia was a result of childhood rearing environment. Then Meal integrated his existing psychodynamic theory into neurobiological framework quite meaningfully. And as sir was saying, this topic has been around for a while, but proper research paradigm has been happening for the past 25 years. So just to set a context of the situation, I would like to just put one slide as to what Meal proposed. What he proposed was dominant schizoseme theory, which said that there was a schizoseme which was, for lack of better knowledge, he used autosomal dominant, which is the genetic component, which manifests on a cellular level and causes hypophysia, which is a functional control aberration, which happens at the cellular level. And when there is impaired signal processing in neural circuits, it leads to the neurointegrative deficit called schizotaxia. And when this schizotaxia actually interacts with the environment and social reinforcement schedules, apparent schedules, it causes behavioral symptoms called schizotypy, which includes neurological soft signs, cognitive slippage, and effects on personality and emotions. Then, for it to present and manifest as schizophrenia symptoms, he proposed this concept of polygenic potentiators, which is non-specific genetic traits like anhedonia, ambivalence, and social fear. This he proposed in 1900s, and I think it got published in 1962. He went against his own community and propagated the genetic component, and he integrated the psychodynamic component, and he conflicted with them. And it still holds good. So the context is what we are trying to do here is what at-risk mental state does is it is trying to predict psychosis before it actually happens. So most episodes of psychosis are preceded by a prodromal period. So attenuated psychotic symptoms and impaired functioning is usually happens before the first episode of psychosis. So if when is the right time to identify? The sooner the better. So it actually tries to identify psychosis much before it happens. So that was what Sir was telling called prodrome. If identified in young people, possibility opens for pre-psychotic interventions, which may actually delay or even prevent the onset of psychosis. That is the whole context of the at-risk mental state presentation. So previously, so now you have to identify people at risk. So on whom should you identify on this entire general population? It is very difficult. So there is the high risk group and there is the ultra high risk group. So previously what the easy way is, you see a psychotic patient and you identify the relatives, and solely on the relatives you try to identify whatever traits they have or states they have. That is the high risk group. What is the ultra high risk group? Ultra high risk group identifies risk factors, not just in the relatives, it identifies trait factors and state factors. In trait factors, there is genetic loading due to schizotypal personality disorder and family history of psychosis. In state factors, there is mental distress and deteriorating function. So the concept is identifying before the onset of psychosis. The focus is on the age group 15 to 25. Why? Because the highest incidence of onset of psychosis happens during that age. This is why ARMS takes ultra high risk and not just high risk. So the overall overlay, I'm just trying to, after going through all the articles, this is what I understood properly. So there is this general population, this is for the benefit of the PGs. There is this general population in whom you have to identify the at-risk mental state individuals. And from there, so you cannot do it on everybody. Now you have to select a group where you have to identify. So there is this Melbourne high-risk criteria which is proposed, which narrows down your search, which includes three parts: age between 15 to 25 years, help-seeking individuals and individuals referred to specialist service for help, and marked decreased in functioning based on social and occupational functional assessment scale. That is what SOFA stands for. So here they clearly demarcate that there should be 30% reduction in the scale symptoms, which happens over a period of 1 year, or constant reduction of greater than 50% in 1 year. So that is how they identify people whose functioning is coming down in the age group of 15 to 25 and who have actually gone to specialists in need for help. So this narrows down your search, and these are the high risk people. So now you have to identify who will progress and who will not progress to psychosis. So the scales which will help us are Prodrome Questionnaire 16, which is a self-report instrument, and schizophrenia proneness instrument. And the actual scale which actually helped me prepare this PowerPoint is Comprehensive Assessment of At-Risk Mental State, called CAMS. This is an excellent scale with excellent slides, which actually gives the context of what ARMS is. So when you apply this comprehensive assessment of at-risk mental state, you get state and trait factor individuals, as we previously mentioned. In state, you have, again, brief, limited, intermittent psychotic symptoms and attenuated psychotic symptoms. In brief, limited, intermittent psychotic symptoms, what you have is duration less than 1 week in a period of 1 year, and it resolves spontaneously. There are psychotic symptoms, but they resolve spontaneously. Attenuated psychotic symptoms are symptoms which are subthreshold, which are present on and off throughout the year and not more than 5 years. And trait is, which is straightforward. In the scale, there is a clear pointer which actually asks the individual whether you have a family history of psychosis. And if he says yes, then he goes into that, and you identify schizotypal personalities and first degree relatives, who are obviously at risk. So when you identify these individuals who are at ultra high risk, you follow them prospectively. So when you follow them prospectively, what are you looking for? You're looking for transition to psychosis. So what will help us is, what are the intervention studies which are already there, the treatments which are already applied and proven, what are the ethical issues that we deal with while treating these individuals who are at ultra high risk, And the staging model, if there is one slide which I want to, which everyone to take home, is the staging model of psychosis, which is a once for all answer to all the questions where I found. And there is this trans diagnostic model, which Sir was also mentioning, where there is a pluripotent progress of the disease, and then there is the take-home message. This is the overlay of the entire presentation. So the retrospective view, the paradox or the irony here is, you identify the prodrome symptoms, but you cannot name it as psychosis until it crosses the threshold of psychosis. So once it crosses the threshold of psychosis, it is called psychosis, and in retrospect, you identify that it is a prodrome. So prodrome can be named only after the episode of psychosis happens. Until then, you can have all the suspicion, you can have a query, but you cannot diagnose it as prodrome. That is the paradox. So all the studies that are there are retrospective. So a prospective view is, you identify these high-risk individuals who are at ultra high-risk individuals who have at-risk mental state, and you longitudinally follow up these cases, and you try to identify as early as possible in order to provide supportive therapy or prevent or delay or whatever help we can provide. So these are, see, this slide actually shows us what true positive is. Suppose, say, this is X and Y axis respectively, there are time and symptoms. So these are the prodrome symptoms, and there is a threshold for the diagnosis of psychosis, and the individual has symptoms. When he was in prodrome, it proceeds linearly, escalating, and it crosses the threshold, and it becomes true positive. So this is a clear case. So you have identified the ultra high risk individual, and you have followed him prospectively, and he has become psychotic. So this is a true positive. So positive here is ultra high risk, and later it becomes positive for psychosis. So second thing is false positive. So the person starts with prodrome, but instead of progressing into psychosis, the symptoms resolve. So they do not cross the threshold for diagnosis of psychosis, and hence it is false positive. Why is it positive? Because it is positive for ultra high risk, but it ended up being false because it did not turn out to be a psychotic patient. So this is false positive. The third one, which is very interesting, is false positive. So actually the trajectory shows that this individual has a prodrome, and he's supposed to go and cross the threshold and become psychotic. But what happens is, you intervene in between, because when you find out that he's having trouble, you provide whatever care, and the intervention causes resolution of symptoms, and he becomes false positive, which is true positive in the sense that if left unintervened, he would become positive. But because we have intervened, he has become false positive. But this is a gray area, because you are assuming that he would become psychotic if not intervened. So ultimately, this summarizes identification as ultra high risk individuals. So people who transition to psychosis, they are true positives. Do not transition, false positive. Who might have transition, but because of intervention have not transitioned, is false positive. So in order to increase the predictability of the ultra high risk individuals, because you identify so many ultra high risk individuals and you follow up with everyone, and you never know who will progress to psychosis, who will not progress to psychosis. So in order to increase the predictability, number of measures were tried. So one of which is biomarkers to predict psychosis. This is an attempt to increase predictability of ultra high risk criteria. So these are the changes which were found at the transition and in psychotic patients. And if these changes you can identify in ultra high risk individuals, there is a greater possibility and probability of your sample becoming true positives. So structural imaging changes are prehippocampal gray matter volume, functional imaging changes in prefrontal cortex and cortical function on the verbal fluency test and their relation to dopamine levels, PET and MRS showing neurochemical changes, which is reduction in presynaptic dopamine levels, electrophysiological markers, P300, sensory gating, and mismatch negativity impaired, which is an auditory evoked potential, which was found to be quite consistent in most patients. The phenotypic markers, which is cognitive deficits such as core theory of mind, working memory or executive functioning, and verbal fluency. But the problem with this is it is not practical in routine clinics. So forgive my judgment, but you cannot do it to everybody. So what is practical rating scales? So rating scales is a more practical approach, and the scales which are tried and tested and proved to be of great use are Prodrome Questionnaire 16, which is a self-report screening questionnaire, CALMS, which is Comprehensive Assessment of At-Risk Mental State, which was proposed by Young in 2005, which is a semi-structured interview. And all the previous pictures I have taken from this scale, because this scale I've gone through it and it is very, very good. And last two are structured interview for prodrome symptoms and scale of prodromal symptoms proposed by Miller. These are used predominantly in USA. CALMS was actually invented in Australia. So these scales which will enhance the probability of you finding people who are at risk. So if you apply these scales to the general population, the predictive value will be very low because not all people will have. You have to apply it after you screen the patients. So this slide summarizes everything. So initially what you have to do is, you cannot do the entire scale in general population. You go to a youth center or you identify adolescent group where the onset of psychosis is more, then help seeking individuals who are asking for help, and 30% declining in the SOFA scale. All three must be there. Then you apply CALMS and you find out brief, limited, intermittent psychotic symptoms, which less than 1 week, attenuated psychotic symptoms, and vulnerability group, which is schizotypal and first degree related. So this is the ultra high risk group, and this needs to be followed up, and you have to identify those who actually transition to psychosis. So this is the next rate limiting step in at-risk mental state concept, because you never know who will transition to psychosis. If you identify and they transition, then the sample seems to be very good and you seem to have done a very good screening job. So what recent meta-analysis says is, in 6 months it is 18% transition, in 1 year it is 22%, in 2 years it is 29%, and 3 years is 36%. So I have simplified it. So say after 1 year it is approximately 20, in 2 years it is 30, and 3 years it is 40%. So this is the rate at which the transitions happen in recent meta-analysis, considering all the data available, which is 400 times the population risk for the development of psychosis, which is 400 times. So PACE Clinic long-term follow-up study has done a long-term follow-up study where the transition to psychosis might take 10 years is what they proposed, and highest happens in the 2nd and 3rd years. So under 3 years, whatever transition happens, maximum transition happens there. But if the transition does not happen in the duration of your study, then it happens later, then it is not included in your results. So that is an issue. And after transition to first episode psychosis, this CALMS also identifies first episode psychosis, and only 60% of those transitioning would attract a diagnosis of schizophrenia. So initially the search was for schizophrenia, to identify schizophrenia. But when they found out that after the transition, only 60% fit into the diagnosis of schizophrenia or schizophreniform disorder, then the search went out for psychosis. So what are the intervention studies that are already available? So Vandergag and colleagues reported a number needed to treat of 9 to prevent psychosis in 12 months. So this number needed to, for the sake of PGs, number needed to treat is the number of patients you need to treat to prevent one bad or adverse outcome. So when the number needed to treat is 9, which is a single digit, it looks like a very good number. So another intervention study says that because you have identified symptoms of psychosis, should you start them with antipsychotics? Early enthusiasm for the use of low-dose antipsychotics proved unfavorable cost-benefit ratio. So many non-randomized clinical trials without placebo control suggested benefits of antidepressants and amisulpride. So I will explain all this in the staging slide, where you can use antidepressants and when it is used. I'll explain in detail. and single placebo controlled trial of omega-3 fatty acids was promising. So these are the intervention studies that were done and have proven to be, at this stage, if you start omega-3 fatty acids, it was found to be useful. So what are the ethical issues that you face? So because the patient is not diagnosed as schizophrenia or first stage psychosis or first episode psychosis. So when somebody comes to you and says, these are I'm having odd perceptual abnormalities, I'm magical thinking symptoms, or some perception, I'm hearing something or looking. So you say, when you say it is normal, so maybe if it turns out to be something later, then there is a chance of you normalizing the unusual experience. The other way around is when somebody tells you symptoms which are actually close to normal, because this is a spectrum, and with suspicion you pathologize this. So that is the issue. That is an ethical issue dilemma that we face, because when the patient asks you, is it okay? Then what are you supposed to answer? The second thing is stigmatization and labeling. If suppose you say that because your father has this thing and there is a chance of you getting maybe 13% or something. So then there is stigmatization saying that, okay, if you fit into ARMS or ultra high risk ratio, people might think, who actually think that he might go into psychosis in future. There might be marriage issues, job issues, and labeling. What is self-stigmatization? The patient himself stigmatizes and feels that anyhow I will become psychotic in near future. What is the point? So treating people too early. If you get over enthusiastic and start them on medications, then the receptor novelty will go away. So treating people too early is another ethical issue. Risk of over treatment for false positives. So if they turn out and I showed you the slide, that not all cross the threshold, some resolve, and there is a risk of over treatment in these patients. And genuine appreciation of high risk may cause paradoxical effect leading to increased transition. This is when you actually tell them the actual findings of his symptoms. He might have a paradoxical effect, like he might feel that, okay, he might get stressed, and this might actually increase the stress, and this might lead to transition. These are the ethical issues that were pointed out. Not that I agree with all of them. So 2 articles that criticize services for ARMS individuals were Morris et al. And Ajnakia et al. In 2019, this was proposed. So Morris et al. Proposed 4 and the other person proposed another 3. And there was another article published in 2021, I think, in response to this articles, which I found very interesting. So there is this ethical issue and the answer to it. So the first ethical issue is stigmatizing and cause fear of psychosis. The answer given to it is it may be beneficial by offering a hope of treatment, comforting that there are others, because we do a structured scale and we ask the same questions to a lot of people. It is comforting to the patient to find out that maybe others are there who are having similar symptoms. Services should avoid being located in mental health institution. This was actually proposed, where PACE clinic was established in adolescent health service, later moved into a shopping mall just to avoid stigmatization. This happened in Australia. And always to use non-stigmatizing names. So if you see the names that are already there, these are the programs which are doing immense research. PACE is personal assessment and crisis evaluation. OASIS is outreach and support in South London. EDIT is early detection, intervention treatment, peer Portland identification and early referral, and clinic for assessment of youth at risk. So they avoided all the jargon of psychosis, at risk mental state, and named it in such a way and did not label. So this is one way of non-stigmatizing. So the second ethical issue that was proposed was long duration of untreated psychosis weakly correlated with poor outcome. So this is very interesting, where systematic review and meta-analysis showed that if the duration of untreated psychosis is less than 9 months, and if we intervene in before less than 9 months, there is greater reduction in the negative symptoms. So the response to negative symptoms is better if the intervention happens before 9 months. So even this, there is an answer to this criticism as well. The third criticism has poor predictive value for psychosis. So previously we studied that after 1 year it is 20%, 2 years 30%, 3 years 40%. So even if you take after 1 year 22% of at-risk mental ARMS individuals transition to psychosis within 1 year, which is higher than mild cognitive impairment progressing to dementia, which is 9.6, and pre-diabetes to diabetes, which is 5 to 10. So it is almost double and triple to that, and 4 times to that. So that criticism is also not totally correct. And the last one is little evidence that intervention prevent transition to psychosis. So services should provide needs-based care. So don't intervene, you support them and do not use drugs is what is predominantly saying. And the answer to that is symptoms and functions improve even with non-specific treatment, and attenuated psychotic symptoms associated with a range of poor outcomes. So sometimes it becomes necessary to intervene, and it is based on the judgment of the clinician. So these are the ethical issues, the criticisms and the responses. So this is the PACE clinic's approach to treatment, where they propose that assessment, formulation and engagement should be done. Psychoeducation should be given to all patients and family. Individual case management includes ongoing monitoring of the client's mental state and risk. So continuous monitoring, ensuring that the client and family or carers are appropriately informed about the nature of the mental health problems and their treatment, reducing the trauma or anxiety associated with any necessary inpatient admission, and facilitating adequate treatment for comorbid disorders, which can be depression, anxiety, substance use. So the continuation of it is assisting in adverse impact of the illness, fostering recovery, reintegration into society, and restoration of the developmental trajectory, and risk assessment and management. Family interventions must be done, and CBT. This is proposed by PACE Clinic. But actually, my favorite and the one and all staging model of psychosis, which was proposed over the last decade, which actually answers most of our questions. So this defines psychosis as a continuum. So they have proposed a stepwise treatment for psychosis, because from ARMS to ultra high risk to all the BLI, IPS, APS, schizophreniform disorder, because it happens in a continuum. Even the prodrome, there is a demarcation called early prodrome and late prodrome. So the treatment also should be catered to that. So staging based on severity of symptoms and levels of distress and disability. So different interventions recommended at each stage to prevent progression to the next stage and promote recovery. So this is the staging model of psychosis, where stage 0 is no symptoms or increased risk, which is still ultra high risk. And you do all the supportive treatment, needs-based treatment, non-pharmacological management, which is improved mental health literacy, family education, and drug education. So stage 1A is when mild or non-specific symptoms and functional decline is present. And here the point is there is cognitive behavioral therapy, and is in addition to that, there is active reduction in substance use, which is very important, because the only absolute factor which was found was use of substance, use of cannabis. If you can stop that, it can actually prevent the precipitation of psychosis. So stage 1B is the first stage where the use of medication starts, which is omega-3 fatty acids and antidepressants to treat all the comorbid conditions, along with all the other interventions which are given for 1A. Stage 2 is the first stage where the actual full threshold psychosis develops. Here, there is the first use of atypical antipsychotics. Stage 3 till 4 is the various remission and relapsing stages. For example, this is incomplete remission. This is recurrent stabilized with residual symptoms, then multiple relapses, then persisting and unremitting. And the treatment caters to that. So I have tried to simplify the slide. So the first stage is no current symptoms, which all the family education and drug education. Second, the stage 1A is help seeking with distress. Here there is cognitive behavioral therapy comes into role and reduced substance use is advised. Stage 1B is attenuated syndrome, where the first use of omega-3 fatty acids and antidepressants come into play. And stage 2 to 4 is full threshold disorder with varying degrees of recurrence and severity. Here you can use antipsychotics, and based on if it is treatment resistant, then you go for clozapine. If there is multiple relapses, you go for stabilizers. So based on the need, you can, but the actual stage where the psychosis starts is stage 2. So the entire prodrome and the ultra high risk of the transition is still stage 1B. This is like the cancer model which is proposed, which is a dimensional approach rather than a categorical approach. And the argument here is when you treat the recovery and the response should also be dimensional. So the next concept here is transdiagnostic risk. The clinically high at-risk mental state, which is CHAMS. Here, what it is proposed is, here initially the search was for schizophrenia, then the search translated to psychotic search for psychosis because the trajectories increased. Now the concept has changed, which is the clinically high at-risk mental state, where there is transdiagnostic risk, where syndrome warranting treatment due to help seeking and distress associated with symptom below defined threshold for diagnosis. That is stage 1B, which comes before stage 2, because from stage 2 it is full threshold psychosis. So the subthreshold states covered are, apart from attenuated psychotic symptoms, which is also covered in the ultra high risk criteria, subthreshold bipolar state, mild moderate depression, and borderline personality features are also included. So the entire spectrum is covered, and the sample size and the symptoms that which they present is more symptoms are taken into consideration. And the next thing what they did is, in trait vulnerability, the relatives of patients with psychotic disorders was taken. Here, trait vulnerability expanded to include history of serious mental disorder in a first degree relative, in addition to the functional decline. So first degree relative is also asked if he has a relative who has severe mental disorder, serious mental disorder, and that also is taken into consideration. So now number of factors are taken into consideration, and the evolution of these symptoms is followed up. So evolution of symptoms may not necessarily follow homotypic course, where subthreshold psychosis becomes psychosis, but maybe heterotypic, where moderate depression without any psychotic symptoms might turn out to have first episode psychosis, or the other way around. Maybe attenuated psychosis turns out to be bipolar or depression, the other way around. So heterotypic is they follow different trajectories. So pluripotent risk paradigm tackles shortcomings associated with ultra high risk, which states that you are covering all the symptoms and you are also allowing it to progress in the way it should, and then identify all with all the micro and the macro phenotypes. So allowing capturing broad range of outcomes and higher transition rate to serious mental disorders in general. So instead of searching for one thing, we actually take whatever we get and we try to help them. And a suitable design for such complex study is called SMART, which is sequential multiple assignment randomized trials, where which is tailor made for a diagnosis like clinical staging model, where multiple intervention stages that correspond to critical decision. So intervention happens at multiple stages whenever required. So forgive me for lack of clarity, but this slide is very important. So here there is increasing severity of symptoms and disability on the scale, and from stage 0 to stage 4, which I previously explained, from asymptomatic they progress to treatment resistance. But here in this slide, what is important is the ultra high risk, which can be shown. So that is in the stage 1B, because after stage 2 it becomes psychosis. So here the different shapes of all the black dots represent different types of symptoms, say psychosis, say flips, say depression. So all these things are identified, and in that we go and identify the psychosis or first episode psychosis, what all are leading to first episode psychosis, which is the context of at-risk mental state. So in clinically high at-risk mental state, the difference here is everything is same. You still identify it in stage 1B where the subthreshold symptoms are only there. But here the difference is you identify all the symptoms, macrophenotype and macrophenotype, and the multiple trajectories that it is going into, like say depressive disorder, bipolar, psychotic person, substance use. So that at a stage it was mentioned that from the ultra high risk criteria, there were 17 trajectories going into different, progressing to different serious mental disorders. So this, where the macro phenotype, the circle that is showing is kind of identified similar symptoms, and phenotype is nothing but the group of organisms having similar characteristics objectively, where the genotype interacts with the environment. So these are the people with substance misuse, these are the people with personality disorders, and they are handled accordingly. So this covers a greater range of symptoms and greater outcomes also. So it is a much wider range study. So my take home message is the key characteristics of a disorder are severity and persistence of symptoms. So I have kept this slide because if there is symptoms are severe and if there is persistence, then some kind of intervention must happen. Clinicians and patients who have to make decisions about treatment must follow a pragmatic approach, which is a practical approach. Dimensional rather than categorical approach, which is the staging model. And this is subject to argument, but in this case, it is the dimensional approach which will help you, because in categorical, the diagnosis first will come out. Here we are still looking for outcomes. Staging model, more accurate guide to treatment. If you follow the staging model, it is one-stop answer for all the questions. And the risk-benefit ratio. How aggressively to intervene with balance in favor of slight over-treatment rather than waiting for treatment failure. This is my personal opinion. So I would like to end by saying that if you go into an epidemic where there is malaria and you call some person and you tell him that, Acha, there is an increased malaria, there's a lot of mosquitoes here, so you better be careful, use nets, use whatever precautions. And if he says that, how do you know that this mosquito will bite my son? So there is no answer to that. No doubt the question is stupid, but you cannot answer that person because you do not know. But a better question is, how do you know that this mosquito won't bite that person? So it is easy to critique, but without actually the symptoms presenting to identify and to provide some help. So I am more in favor of a little over treatment, but caution with antipsychotics. Sir, thank you very much. I hope I was audible to everyone. Sir, over to Chairperson, sir.
Hello?
Sir, over to you, sir. Thank you.
Topic is over.
Yes, sir. Yes, sir.
Very
Sir,
good.
Ramesh Babu sir, ఏదో question అడుగుతుంది. Ramesh Babu sir.
Am I audible to you?
Yes, sir. Yes, sir. Yes, sir.
It's a very nice topic, Prabhath. Congrats for giving excellent lecture.
Thank you, sir.
Some may saying
Sorry, sir. It was not audible.
I'm
Sir, it was not audible. It's not audible.
So, I think as ARMS on how to manage this patient.
Ramesh Babu sir, audible లేరు.
సార్ అక్కడ నెట్వర్క్ లో ఉంది సార్, నెట్వర్క్ బాగాలేదు సార్ దగ్గర.
ఓకే. Ramesh Babu sir, audible లేరు.
You know, I'm not audible.
Yes, sir.
యువర్ నెట్వర్క్ ఈస్ టూ లో సార్.
Sorry, sir. I could not get your question, sir.
Nagi Reddy sir, చెప్పండి.
Ah,
మీరు ఏదో చెప్తున్నారు.
వినపట్లేదు. హలో?
Yes. Ramana Rao sir.
Yeah, yeah. It's a very good presentation and a very clear presentation.
Sir,
I truly appreciate the speaker.
sir,
One doubt from my side is
sir.
there's nothing much that is discussed about the treatment part of it. Of course, I do agree with your statement, and then that is over treatment is better than the under treatment, definitely. But day-to-day practice, it's really a genuine problem for the families,
Yes, sir.
because there is a strong family history in the case which I'm talking about. The grandfather is having a classic schizophrenia, and the sister who refused treatment have become a very functionally deteriorated condition and psychotic. Of course, not to the extent of calling it as a schizophrenia, but this guy, her brother, is having again symptoms. So they are from a very influential family, and they have the fear that drugs may be given unnecessarily. But each time I will convince them, it requires medication, requires continuous monitoring and
Yes,
all
sir.
that, because we have seen 2 generations already suffering, and this person should not suffer it. I think personally, I believe that if it is a over diagnosis or over treatment, then that is better than allowing the treatment gap, so that the person will become chronic. That is the case which we have seen transgenerationally in this particular case which I'm discussing. So over to you, sir.
Sir. Sir. Sir, your voice is not clear, sir. Voice is not clear, sir.
Omega-3 fatty acids.
Sorry, sir.
Omega-3 fatty acids.
Role of omega-3 fatty acids.
ఏంటండి?
Role of
Omega-3 fatty.
omega-3 fatty acids.
Omega-3 fatty acids. Yes, sir. Sir, in the staging stage, actually there is one single clear placebo study which showed that omega-3 fatty acids is helpful, but they failed to replicate it in the consecutive studies. But that study showed so much promise that it's not wrong to consider, sir. When there are no psychotic symptoms and there are no comorbid depression and anxiety symptoms, but clinically, when you have an eye with your experience that it looks like prodrome, there is nothing wrong with going with omega-3 fatty acids.
Sir, very good. Sir.
Prabhath,
Very good, sir.
Hello.
Hello, sir.
Audible now? I put my question. I typed my question in the box.
Chat, sir.
First,
Any questions in chat?
Can I ask, sir, can I ask Prabhath? We may be getting some persons approaching us with fear or phobia, to mental ill persons. Can we call them ARMS, and how to manage them?
Sir, in the scale for it to be diagnosed as at-risk mental state is a even bigger concept. To diagnose it as having ultra high-risk criteria, they have proposed 3. One is 15 to they should be in the age group of 15 to 25 years. 2, there should be help seeking, which what you're saying fits in help seeking. And 3 is decrease in the functioning. So in the past year, there is significant decrease in whatever scale. So if these criteria are met, then you can actually apply this calm scale, which is available. And if it fits, then definitely you can fit in into either straight or trait. Not all individuals. So you should apply the scale, either prodrome questionnaire 16 or CALMS. But for you to apply in this large sample, it is very difficult. So it should fit in the criteria of high risk, which is 15 to 25 as decreased functioning, and so one of either of all this. But these criteria must be there. All 3 must be there. 15 to 25 functioning, and the third thing is help seeking.
Because any significant advancement in the research about biomarkers, especially neuroradiological as well as genetic studies. So most of the time we have to depend upon again the scale or clinical judgment, our own clinical judgment and personal judgment and our wisdom,
Yes,
seeing the patient. These things also play some role
Yeah.
treating
Sir,
such kind of
for-
persons.
For at-risk mental stage, the experienced clinicians' eye plays the major role, is what I understand, sir. Because even to apply the scale, you have to identify whom to apply the scale.
Other questions?
Sir, can I, sir? Hello.
Lokesh sir, adagandi.
Thank you, Prabhath, for the excellent lecture. My query is because we are in a stage where schizophrenia patients reaching treatment is still delayed because the duration of untreated psychosis is still delayed. Are there any guidelines that we should screen for all the family members of a patient
Sir,
to identify
yes,
high risk cases or at-risk mental state, high-risk at-risk mental state? So are there any guidelines that, because we see a schizophrenia patient, is it mandatory for us to screen for in the first degree relatives at least for this high-risk behavior?
sir, that could be, in my opinion, the more practical thing to do, sir. Because so if there is somebody, some young fellow gets his father, and if suppose he has permission, would be very, because as one of the slides says, if you identify them and treat them before 9 months, there can be significant reduction in the negative symptoms. So the guidelines remain the same, sir. But this is called high risk group. So the expanded horizon is the ultra high risk group where you are screening the entire population and identifying people. This is the high risk group where you do it in first degree relatives of patients with schizophrenia or psychosis. So after that, once you identify, then there is the prodrome questionnaire, the CAMS, the scale, and everything remains the same. And then they will fit it to state or trait, and then the follow-up.
Thank you.
Very good.
Sir.
Any other senior persons, comments? Dr. Uday?
Yeah. May I, sir? Am I audible? I've been watching that there are audio glitches there. Am I audible, sir? Sarat?
Yes sir, yes sir.
Oh, very good. First of all, I would like to thank Dr. Prabhath for a mind-blowing lecture. He has brought many of the important points about the indexed topic. And also thank the EC members to CME Committee to choose this topic. This is a very wonderful and need of Java to know about this concept. At-risk mental state, I would what I would understand is it is a surprising state where an individual or a family member to perceive that there is something wrong, something is happening, which is not normal. So from that stage to becoming psychosis, it's really a fearful state where they experience. Young onset psychotic society founded by Jacob John in Melbourne. They are the pioneers in this concept. They have brought a lot of understandings and scales even to measure these concepts. I think we should thank them. Unfortunately, we don't have a prevention or treatment methods for at-risk mental state. That is an unfortunate issue now. And only a comprehensive assessment of at-risk mental state comes probably the most promising tool to understand and detect who is at risk. Probably that may be useful for family members also to detect. Mostly the risk factors like family history, when especially both of them are having schizophrenia, substance abuse and brain injury, bad birth history, bad environment. Definitely, these are the cases which would definitely after the arms to psychosis they might develop. So we should be a bit careful about these patients. I think most of them, family members should be screened. I agree with Lokesh. Finally, this is a wonderful topic which has been brought. NAMI, we know, National Alliance on Mental Illness, found the age of onset is 24. Age of onset is 24, but 50% of 24 percent of population do have psychosis at the age of 14 years. I think we should be a bit careful about this age group where there are vulnerabilities more. So we should be very careful about this population. So finally, I would thank the EC, CME, and the speaker to brought many of the issues regarding this topic. I really felt very useful.
Now I request Dr. Narasimha Reddy, sir.
Sir.
Sir, just a minute. Sir, I have something to say. Sir, this is my superintendent, sir, is here, Ram Reddy, sir. So he was gracious enough to provide me this hall. And sir. So this is Ram Reddy, sir. He wants to invite all of you for the occasion of opening of Center of Excellence, sir, in Vizag. So that is happening very soon. I think it is 1st of August, sir. 1st of August. Sir. So on his behalf, I would like to invite all of you for the opening of Center of Excellence, sir.
Okay, thank you.
Thank you, sir. Thank you. Sorry for the
Prabhath, madam, you are down.
Yeah.
Madam, are you there?
Merit is speaking. Am I audible?
Madam?
Yeah.
Am I audible?
Narasimha Reddy, sir, you are audible.
Please ask your doubt, madam.
No. Is
Hello.
it Dr. Narasimha Reddy garu or me to talk now?
You start, madam.
Yeah. First, congratulations, Dr. Prabhath, for a wonderful presentation on a very different topic, not the usual one. Apart from the schizotypal cluster A personality disorder you mentioned, obviously the other cluster A personalities like paranoid and schizoid also come under the same spectrum. The other thing is, some OCDs and severe anxieties, gradually, there is a transition into the psychotic state. And we can't, really label them as schizophrenic or, just OCD. But there is a transition state from OCD to a psychotic state. And that's one thing. The other things like derealization and depersonalization also might help us, to identify that something is going on in their life, which is something new. They themselves come and present that something is going on in the life I'm unable to pinpoint. It may not be, the typical florid hallucinations and delusions. Apart from that, even something like anorexia nervosa, and I'm glad you brought up the cannabis, and even gender dysphorias also can, at some point of or other, because of their confused state, they can go into things like schizophrenia. So your take about it?
Madam, actually, after the ultra high risk criteria, the calm scale, which sir was telling, the entire thing that I actually presented is based on Australian research only. The young in 2005. So after applying the scale, when you get the attenuated psychosis symptoms, the brief limited in that, I did not keep it in the slides because of lack of space, but the symptoms mentioned were odd perceptual abnormalities, which you were mentioning, referential ideas, magical thinking. So all these were the symptoms which do not exactly like the psychosis threshold is not crossed. The symptom threshold is also not crossed. Like it does not become a delusion, but still there are ideas of reference and overvalued ideas. So in the attenuated psychosis spectrum, those were the symptoms that were mentioned. Sorry, I did not keep it in my slide. very true what you are saying.
Dr. Suhrut, want to?
Yeah, sir. Very good presentation, sir. My only doubt is, aren't we reducing the potential of the patient, future potential of the patient by saying, okay, you can't do this because you may develop these symptoms in the future. You may not go into these fields because you might have some symptoms. So aren't we reducing the potential of future potential of the future patient? Sir?
So very true. That is why I actually went into in detail in the criticisms and the ethical issues that were mentioned, sir. It says that if you tell the patient that he is having attenuated psychosis symptoms, which is actually included in the DSM-5 criteria as well, then how would a potential girl who is supposed to marry him would look at him? If he is found in some burglary, how would the legal system look at him? So that is all there, sir. But in this process of not doing, because the only argument here is to do no harm versus doing harm. So that is why I said be very cautious on starting on antipsychotics. But antidepressants, if he's having depressive symptoms, anxiolytics, omega-3 fatty acids, supportive therapy, CBT, which actually do no harm, can actually be applied.
Thank you, sir.
Thank you.
Narasimha Reddy, sir.
Thank you. Thank you for the opportunity.
I would like to ask one question, Prabhath.
Yes, sir.
You are
Narasimha Reddy,
saying that neuroradiological methods and genetic testings are not practically available in our settings. But if they are available, where they are available, are they really contributing at present to make such a diagnosis or make such a any differentiation? Does these things are making now?
Sir, I got, sir, the only thing here is you identify the true positive cases, sir. So how well you identify the true positive cases? Because if you increase when you do apply all the domains that you have, all the instruments that you have in identifying and creating a proper filter process and identifying actual people who transition to psychosis, it was found that if the true positive cases percentage increases by 20%, then it is much more likely to cause better intervention, better results and all. So in that process, one of the things is what the biomarkers, if at all available, say if not MRS, maybe EEG. If EEG is available and these are the findings which are found in actual transition psychosis or actual psychosis, if you have a doubt if that finding is there in that particular relative, so that can add to the true positive cases, which in turn will increase the value of the research.
Can I speak?
Narasimha Reddy, sir.
Yeah.
Sir, please.
At the outset, I would like to congratulate Dr. Prabhath for his excellent presentation and answering the questions. I think this at-risk mental state is as an age-old concept. I think, as he has already rightly pointed out, it started a long time back, but it has been subjected to several criticisms in the past itself. Again, people are trying to make it viable in the recent past. I think why it has been subjected to so much of criticisms, I think there are so many ethical issues as well as the legal implications. Because, ethically speaking, so first of all, I think this concept was arised only for the sake of identifying the at-risk for schizophrenic illness in the beginning. But over a period of time, I think the concept has been expanded to the other disorders, like including the psychosis or even BPAD, BPD, like that, several disorders. When it comes to the ethical issues, I think we do not know how exactly the concerned individual is likely turn out to be, whether he is really going to be a schizophrenic or really going to be a bipolar patient or some other BPD patient and all that. So without getting much conclusive evidence to which the diagnosis he is going to land in, I think what exactly the treatment we are likely to give. Is it ethically right? That's one point I think several people have raised, and the other implication is the legal implications. For example, if we try it wrong and the diagnosis turns out to be, how exactly we can face the legal implications about it. The other one is, as far as the ongoing revisions which are going on in the ICD classification systems, maybe over a period of time, the categorical approach, we are still running in the categorical approach. Maybe over a period of time, just like ICD-11 is giving importance in the dimensional approach. In such cases, I think we may have the provisions for identifying this at-risk disorders. And in such cases, I think this concept may go well. I think we may have to wait for some more time. But as a concept, it's a very good concept, because we'll be able to identify the patients at a very early stage. I think it's more than a primary prevention. It's more than a primary prevention, and we'll be able to identify some of the at-risk patients. But we need to look into the ethical aspects as well as the legal issues at the present stage. That's my impression. What do you say about Prabhath?
I totally agree with you, sir. But the thing is, without if at all the patient crosses the threshold of psychotic symptoms, then there is no doubt, sir. Before that, everything is everything is unethical or ethical. So the point is, it should be tailor-made to the insight and the mental capacity of the patient and the relatives. So if they have the capacity to understand, so if he is having anxiety symptoms, depression symptoms, this would help. And if they are ready to take it, then all good, sir. But if they go to somebody else, and if you have started us on medications without actually diagnosis, then supportive, non-pharmacological wait and watch is the right approach to save our own skin, sir.
Prabhath.
Sir, there are some questions in the chat box.
Yes, sir. Identify.
Why don't you read out?
Okay.
Prabhath.
Yeah.
Identifying risk in children.
Children, in the sense that at the entire risk is at ARMS is based on 15 to 25 years.
Okay.
So that is adolescent group, whatever group. Children research, not much research. This entire this is outside the context. If it is 15 to 25, then it fits in.
Next question: antidepressants in attenuated psychosis, can they worsen psychosis?
They do not worsen psychosis, I'm hoping. But if it is a comorbidity and if it helps and if the patient tolerates, then well and good.
Another question: in clinical practice, when can we call it as stage 1B of psychosis? What should be the duration of subthreshold symptoms to call it as stage 1B?
Stage 1B, 1A is in distress. Stage 1B is the stage before psychosis. Attenuated psychosis syndrome symptoms should last at least 1 week for the last 1 year, but not cross more than 5 years.
The last question is, what are your suggestions regarding applying this in our Indian setup, especially in government hospitals where the caseload is high and there is shortage of time to apply the scales, etc.? Do we need any further certification to utilize these scales?
It is a very good research where we have a lot of population. As Sir was saying, we can apply it to, even if we apply it to relatives, we will have more data than more countries can even ever imagine. But if you have to identify the actual topic at hand, then it is in the OST centers where people actually have all these substance uses and all. There it will be a very good population, adolescent centers. In Indian scenario, if you identify first degree relatives also, it is a lot of help if you can actually stop it or delay the progression. That is my opinion in Indian context.
Thank you, Prabhath. No more questions.
Sir,
Thank you, Prabhath.
Thank you.
Okay. Now, Narasimha Reddy sir is Sir, Narasimha Reddy, sir. I think it's time to finish this topic because it's already 9:15. It's a wonderful presentation, Prabhath, and others also participants. I thank all the participants and all the speaker for their wonderful presentation and their contribution for this topic. I thank organizers. Now I hand over the platform to organizers.
Yeah, it is wonderful presentation. The Prabhath, the success is almost like Prabhath's movie. Prabhath movie is wonderful thing. Now I am very hopeful that we will get very good speakers from Andhra Pradesh also. Now I request Dr. Ranjit to propose vote of thanks.
I would like to thank Dr. IVL Narasimha Rao garu and Sarat garu for this wonderful brainchild of theirs. Hope many young speakers go on to become eminent and eloquent speakers. I would like to thank Dr. GV Ramana Rao garu, the CME chair, for charting out this beautiful and novel program. I would like to thank Dr. Dr. Prabhath for speaking in such a beautiful manner, in such a lucid manner. And like Sir said, he started the innings with a 4 or a 6. And I would like to thank Dr. Nagi Reddy garu for chairing this session so wonderfully and beautifully. I would like to thank all the participants who attended this and for asking so many questions and being very active during this presentation. And I would like to thank the participants and also Exigent Pharma for their sponsoring the program. Thank you, everyone.
Thank you very much.
Thank you, sir. Good night.
Thank you. Good night.
Good night, sir. Bye, sir.
Bye, sir.